Hi, my name's Dr. Steve Flamm. I'm the director of Transplantation Services for the liver unit and also clinical research at Rush University in Chicago. And welcome to today's podcast talking about a very important topic in the field of liver disease, MASH. I'd like to welcome my two fellow discussants, Dr. Kim Brown and Dr. Nancy Reau. This is a very exciting time in the world of liver disease because finally we have some advances for therapy for MASH. Kim, do you mind just talking about briefly the change in terminology? Because some of the, some of the audience may be unfamiliar with it.
Yeah, it's there's been a lot of work actually on the change in nomenclature from what we used to call NASH or non-alcoholic steatohepatitis to MASH. And if you look at the change, it's really bringing in the other metabolic components, which I think was important. We always knew, right, that these patients were metabolic. They had diabetes, hypertension, hyperlipidemia, but it really wasn't well described. And the relationship of all of those factors as it, relates to disease progression, I think this is just better terminology. The other terminology that I like that has now introduced is the MASLD. I think we had a lot of patients that were metabolic, but also took fairly significant quantities of alcohol, and we never knew how to characterize those individuals. But clearly they, likely had components of both.
And Nancy, I certainly know your practice because we work together, but how common are you seeing people with fatty liver disease, and what are the characteristics of them? What aside from the fatty liver itself that we commonly observe?
Yeah, and so first, Steve, fatty liver I think is a term that we stick to, even though in theory we should be talking about steatotic liver disease. But I feel that the vast majority of my clinic has a component of fatty liver, even if their referral is for hepatitis C, or their referral is for abnormal liver enzymes, or they come in with autoimmune disease. I think these metabolic risk factors and the component of steatotic liver disease is pretty significant. Now, I know that epidemiologic studies, so if you quote the statistics, about a third of America and probably a third of the world is at risk for fatty liver disease, of which only a small component is at risk for this more progressive, aggressive form of MASH. But in liver clinic, and I would imagine most medical systems where people are going to be enriched in these complications, we really feel like it's the vast majority of our patients.
And in my practice too, I have the same patient population, basically, I think, as most hepatologists do. The majority of my patients also have components of the metabolic syndrome, type 2 diabetes, hypertension, hyperlipidemia. Is that the way patients look in Michigan as well with fatty liver?
They do. We have, obviously, and I think we talk about this today in the conference. We talk about lean NASH. We don't see a lot of lean NASH. Most of these individuals are fairly metabolic, carry additional weight. But that's another thing that, I think this conference has really brought out how to identify the patient who's lean, maybe not showing up to your clinic and in the obvious form, but how to identify that individual, work them up, and even consider them for treatment.
Yeah, I think that a lot of concentration for identifying fatty liver disease has been in our metabolic patients. Exactly. So if you're looking at the lowest hanging fruit, if you have a person who's got insulin resistance or diabetes, you should be thinking about steatotic liver disease. And if you have obesity and obesity plus another metabolic abnormality like hypertension, obstructive sleep apnea, you should again be thinking about steatotic liver disease. Most of my lean fatty liver are Asian or are people whose BMI is on the lower end, but they are very thick in the middle. They're, I think, oh, this person's got a BMI of 22. Why are they being referred for fatty liver? And then you walk into the room and little tiny arms and legs and a very round little center. And so it's that I think that visceral fat, that adiposity that increases their fatty liver. And they often have genetic risk. I saw a mom who's my patient bring her daughter in. Daughter had a relatively low BMI, but mom had cirrhosis from fatty liver disease. Yeah. And so I'm like, you're just genetically at risk for this.
I wanted to make a comment because you've talked about steatotic liver disease. And the fact that we've known for years, right, and we talk about this, Steve, you and I, when in the conference, when we go back and forth about the non-invasive testing, you identify steatosis in a lot of forms of liver disease, right? And that's going to be one of the challenges, I think, in terms of trying to sort out who has steatotic liver disease due to hepatitis B or hepatitis C, and who has what we now consider to be steatotic liver disease, fatty liver disease, or MASH. Those are going to be challenges, I think, that we have moving forward.
I mean, I think it's very important, despite how common fatty liver is, particularly if someone has elevated liver enzymes, that you not forget to work up other causes of chronic liver disease. Fatty liver is common. Most people will only have one liver disease, but some people have more than one. And, you know, we're not servicing patients best if we just assume they have fatty liver and not, even if they have a component of it, and not look for other things. So I think the audience should remember to look for other liver diseases as well, because certainly we see combinations, right?
Yeah. There was an interesting study that looked at the kitchen sink approach versus a stepwise approach for excluding alternative etiologies. So, like, do I just do every test under the sun right on day one, or do I test for some things that are common, and if that isn't the right hit, add more and more? And they ended up being almost the same cost, which surprised me. Because I'm like, we save so much money when we just look for viral hepatitis and iron overload and only add the other stuff if that's not the right answer. And it was less efficient. It took longer to come up with a label if you did it in the stepwise approach. Now, that didn't change my practice pattern. I'm like, that's an interesting study. And I still do the common stuff and only test for like LALD when I haven't got the right answer. But it does validate some of the fellows when they, are doing an AMA on a man. I'm like, you really wanted this? And they're like, yes, we want it all.
Yeah, well, I think that's important. So now that we have, therapies for this, I'd be interested to hear, have you guys started writing prescriptions? What's your experience been?
Yeah.
Whenever there's a new medication, it's always really challenging, right, to get things going. But
yeah, I think probably like you, we have had an advantage in that we have been in the clinical trials for this agent. So I think when you've used something, and I think, Steve, you are our lead PI on this, but you feel a little more comfortable with it because you've already seen it and you're already familiar. The only thing is now access. How do I actually get it? That's the hard step. But I had patients that either could not participate in the trial for logistic reasons or got excluded, but definitely fit the criteria of F2, F3, had already had lifestyle interventions, had risk for progression. And I have written, I think, 3 or 4 prescriptions for this agent for resmetirom.
I don't know. Patients actually gotten it?
I was going to say, I don't know if they have gotten it.
Not quite yet.
My rep congratulated me on getting approved, but I'm like, I don't think this patient's actually started this drug yet. But possibly.
Well, it's important to know too that this is not a drug for everybody.
No.
Fatty liver is a very, very large number of patients, as we said earlier, and the audience needs to recognize that one of the ways we select out the people that we're worried about and who are eligible to get this new drug is by doing fibrosis testing. You either need to do blood tests or imaging tests to actually know how much fibrosis a patient has. And it's only for the patients that have stage 2 or stage 3 fibrosis. Right. And the drug, at the time of this taping has only been out for less than 2 months.
Right.
So I'm not sure how many people have started it yet. But the data look encouraging, I think, for this particular patient population. And I think we should use it. You're not planning on managing their the other aspects of their metabolic syndrome, are you?
No, we probably should, to be honest with you. I mean, we see this, we're all transplant physicians, and we see this in our post-transplant population where metabolic disease is really not as well managed as we would hope it to be. And it leads to complications such as recurrent, liver disease, chronic kidney disease, et cetera, coronary disease. So we have tried to help our colleagues, in primary care do those things, but we really do rely on them to manage the metabolic conditions that these patients have. But I think I think all the data supports the tighter those are managed, the better the patient does.
Particularly weight loss. I don't think we do a very good job with weight loss. We tell patients lose weight and then we walk out of the room and, again, these overweight patients, we're not the first, we're not the first people that ever asked them to try to lose weight in their lives. So obviously they're not succeeding. And I think we need to be more aggressive and have better strategies in terms of how we can help them lose weight, because that may be the best thing of all to actually help the steatotic liver disease.
ASLD and ACE have a combined guideline where weight management is in there. There are guidelines on what kind of agents to use, especially if you're at risk for more progressive fatty liver disease. AGA has a guideline on obesity management from a gastroenterology's perspective, and strongly advocate for ownership of obesity. Our luminal colleagues can do endobariatrics and things as they have wider coverage, so they have more tools. But I prescribe a fair amount of GLP-1s, not for fatty liver disease per se, but if I have a patient who I know is at risk for progressive fatty liver, has obesity, then I am happy to write the GLP-1. If they have diabetes, I try to give it back to the person who is managing their diabetes, because I think that's only polite. And if they come back and they still haven't started a GLP-1, I might reach out to their endocrinologist or their primary care doctor asking if there was a contraindication, or did you not read my note? And then we talk about it. And sometimes it's coverage. Like they're all like, well, I couldn't get it approved. And I'm like, well, there are agents you can get approved. They don't require prior auth. They just don't work as well. Maybe you could start with this one. And I find that those conversations are very successful in getting diabetics on GLP-1 therapy.
Yeah. And I think it's encouraging too, that in the trial data for resmetirom, there were people on GLP-1s, right? So I think that's always a question that I get. If I have a patient on a GLP-1, can I give resmetirom? And the answer is yes, based on the clinical trial.
It was a pretty good
data,
number.
so.
It was about 15%.
It was, yeah. Now they had to be stable on their GLP-1. You wouldn't start them, I don't think, together, but it is encouraging to know that you can safely give that to patients.
How often are you following, if the patients haven't gotten it yet, they soon will, resmetirom. How often are you following patients after that? Because that's not in the label.
No, I think most of the time we start by mimicking the clinical trial, because if it worked in the trial, that will at least be what you should start with in practice. And I think we're looking for markers of success as well as markers of failure. And certainly you can use things like measuring fat by, FibroScan or elastography scores. But even just normalization or improvement in ALT has been shown to mimic histologic outcomes. The medicine in the trials was very well tolerated. So I was planning on, using kind of 3 months as my first marker, expecting to hopefully see something by 3 months. And then we'll wait for more data to talk about futility and success, because you don't want to continue something like this if it's not going to work. I think that the favorable lipid side effects or improvement is also good news, but I don't know that I would use this medicine if it wasn't helping your fatty liver disease, but it was improving your cholesterol.
So can I just ask, when you say 3 months, what are you looking at? Are you reassessing fibrosis or steatosis at 3 months?
To be a supermodel in 3 months.
Yeah, there you go.
No,
but
I think I would be looking at labs.
Yeah.
I think it would be a little bit soon to repeat elastography. I think at the soonest I would do that after 6 months.
Yeah.
But I would mostly just be looking at labs, looking both at lipids as well as liver enzymes.
I mean, I think the trial data suggests that, CAP scores take longer to improve. I don't know if either of you guys use MRI PDFF. We struggle at our institution because our MR, scanners are so highly used. So even though it is possible to do, it's very difficult to do on a large population. So we tend to use elastography.
Yeah, we use mostly elastography. Steve hasn't been at Rush as long as I have, so may not realize that some of our MRIs will do PDFF and some of them will only do elastography. So if you wanted both, occasionally you have to use 2 different machines.
Yeah.
Elastography is pretty easy because it's like a 20-minute MRI, but the fat quantification is a little bit harder for us to get just on the machines we currently have. As they get upgraded, I think most of us will find that these tools become easier to access.
I think I'm going to focus more on fibrosis than the fat itself, actually.
Yeah.
And there aren't recommendations. I'm not sure when they'll be forthcoming. Maybe the societies will update the guidelines to have some direction on this. But I'm going to actually check a liver panel 1 month after. There was one patient in the trials that had a marked elevation of liver enzymes,
Right.
and it was early on. So I'm going to check a liver just blood test at month 1, and then probably 3 months, and I'll do a fiber scan probably a year later. And my hope is that at least there's no change. I would like it to be better, but if there's no change, if there's stability, I'll consider that a success, especially in someone that has stage 2 or 3 fibrosis to begin with. And I will continue on. If it got worse, I probably would consider that futile and stop, because Nancy's right. You don't want to keep something on board that's not working.
Yeah.
They have enough medications, these people, that if it's not working. But it works in a lot of people. And if you can even stabilize the disease in people that we're very worried about, these are people that have advanced fibrotic, moderate to advanced fibrosis already, I think it's actually a very important addition to the regimen.
So, we have all these non-invasive tests. In my practice, I like to compare apples to apples. So if I have assessed fibrosis with elastography by, FibroScan, then I would probably use that same test. Some people are really going to have, biochemical markers, right? They're not going to have access. What would you guys do? I mean, do you have any sense of, if you didn't have access to MRI, if you didn't have access to a FibroScan, or what would you guys use?
Yeah, I order a fair number of ELFs,
Yeah.
The enhanced liver fibrosis test. And I do that often in my patients who have a FibroScan or even an MR elastography that have really high IQRs, the interquartile range suggesting that the value wasn't that reliable. And, because I think then the serum test is probably more reproducible than something where the values were all over the place and they just added them up and gave you the mean or the.
But ELF isn't available in a lot of places, the enhanced liver fibrosis test. Insurance doesn't cover it in some places. And there's really not been a lot of advertising of this test. I don't think a lot of the audience is even familiar with it. They probably should be. It's the best blood test, I think, that predicts fibrosis, but it's not used very much.
I thought LabCorp did it. Is that not true?
They do it, but I mean available in terms of the insurance.
It really is not covered for some patients. But I think my point is, I think it wouldn't be a great idea to assess fibrosis with, one test and then measure response to a therapy with a different test. I think you're going to have to somehow choose your test and follow
Although I will say, I didn't really, I hadn't thought about it that deeply, but I gave a talk about this a week or two ago. And one of the people in the audience said, Dr. Flamm, these tests don't show the blood tests that fine of a measurement of fibrosis. For instance, they show F0 to F2 and advanced liver disease. So somebody said, how do you know if they're F2, F3? Advanced is F3, F4. And this was all of the tests pretty much. And starting to develop some of or to use these tests for the fine determination of stability, or is it improved? They don't give you numbers that actually can make that determination. And I looked, and once I thought about it, they were exactly right. So I think the blood tests are very useful, certainly, but to really look at the fine detail of, is someone stage 2 or 3? Have they moved from 3 to 2 over a year on therapy? I think that's going to be challenging with the current blood tests that we have.
Yeah, I as you know, for our talk, try to dig into the research to look, was there any data looking at the delta or the change as a predictor? And all of the basically blood tests did have significance as it related to fibrosis change. But the area under the curve was so low. It's really, it's very tough to use those, those deltas of a Fib4 or an APRI and really say a lot about them.
Great.
We need some better tests, I think, but.
And we definitely need better tests. And I think that Also, we need to put it into perspective
Yeah.
because if you're F2, F3, you're still much, 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 much more likely to die of non-liver related death than if you're F4. And so we want to keep our patients stable, especially our young population. But if I can keep them there and I don't have something that's perfect and they're not progressing to cirrhosis, I'm pretty happy because at least then the liver is not going to be the main reason that they have a poor outcome.
Right.
A little bit different in our advanced fibrosis population. They're having cirrhosis is much more impactful, especially in our young population. As you get older, above the age of 65, non-liver related death is still higher than liver related death, even in the cirrhotic population. But stability, I think, would be acceptable for me.
Yeah, absolutely. I think that's the goal with all liver diseases, right? I always tell my patients my goal is that you don't, in the end, die of my disease, which is liver disease.
We don't want to worsen their cardiovascular risk.
We don't want to worsen anything, right?
Well, that's great. Well, before we close, Kim, are there any parting comments that you have for our audience about the current time and our therapies for fatty liver, steatotic liver disease that you want to comment on?
Yeah, I just, as you know, I'm the oldest person in this group, so I've lived through this disease for a long time. The fact that, when I was a fellow, this wasn't even considered a disease. If you didn't take alcohol and you had steatosis, people would tell you lived as long as everybody else. We know that's not true. We know it's a huge problem. It's now the most common cause of liver disease in this country. And finally, we have a therapy to try to help some of our patients with this disease.
Nancy, any comments?
I think the important thing is just to recognize the disease, screen and stage. I mean, you got to go all the way back to the beginning of the care cascade. We have to find it and then find who has risk of progression. And then we'll learn more on everything else because time often answers these questions.
I mean, I agree. I think society needs to have a vigilance for this and realize, despite the fact that many people have fatty liver and have no symptoms early on, that it's actually a thing. As you said, it's something to be concerned about, to become familiar with these non-invasive hepatic fibrosis tests, even in practice, to identify people that we're worried about, and then give this therapy that we currently have, resmetirom, and ones to follow for the patients that really, really need it. Well, I'd like to thank you for attending the podcast on steatotic liver disease. We hope you have good luck and good fortune in managing the many patients you will see that have this problem.